question. I'm not going to give you a lot of time. So we're just going to post the question and post the answers immediately. So young adult male presents with severe pain in the abdomen with anorexia, nausea, and vomiting. Pain started around the umbilicus and then shifted to the right iliac fossa. Presently, he has fever, tachycardia with hypotension, with signs of peritonitis, particularly more in the right lower quadrant. He has rebound tenderness, and it's beginning to become quite hard and, cardboard hard rigidity. He undergoes a CT scan because his urea creatinine normal, which is presented. What is the most probable diagnosis? Sorry about that spelling mistake, but that should say most probable diagnosis. The most probable diagnosis is acute appendicitis. Why do we call it acute appendicitis? You can actually see, let me just get that. Yes. You can actually see that there is a fecolith. So what is that? It's a fecolith. Stool in the appendix lumen, which has become very hard. So you can see that that is the lumen. I'm going to take a bit of a narrower white. And so you can see the appendix, which is quite large. And you can see that that is the fecal blocking it off, quite close to the base. I mean, very close to the base, as a matter of fact. You also have lymph nodes, plenty of lymph nodes in the mesentery with a bit of fat stranding. So this is an acute appendicitis. Why should the sequence of pain start around the umbilicus and then migrate down into the right iliac fossa? So that's sometimes asked. So think about it, guys. I mean, when the inflammation is still located inside the appendix. So let me just get a red color. So there we are. That's red. When it's located inside and there's a bit of distension, the appendix stretches. And when it's stretching, don't forget that it still hasn't inflamed the parietal peritoneum. So it's a bit larger. Now, because it's stretching, see, I mean, that arises from the 9th, 10th region, the 9th and T1, T10 and T12. So the pain around there actually starts, that is an ill-defined pain, and that starts around the umbilicus. Sometimes a colicky pain around the umbilicus because this is stretching. The moment the inflammation travels out into the parietal peritoneum, the pain therefore now, which had initially started off there, it migrates down there. So that is migration of pain. So that is the sequence of pain, and that explains what you're seeing on the CT scan. Now, let me get rid of this. Okay, so let me get how is it scored? There's plenty of scoring systems, but the one that is most popular is the Alvarado score. So scoring system is used as the Alvarado score. And what are we missing? The missing criteria is the blood test, which showed in leukocytosis with neutrophilia. So what are the components of the Alvarado score? These are the symptoms of the Alvarado score. You have symptoms, pain migrating through the right iliac fossa, just described it, together with anorexia, nausea, vomiting, all of which are there. What are the signs? You should have a temperature more than 37.3 degrees Celsius, tenderness in the right iliac fossa, and rebound tenderness. So symptoms, signs, 3 symptoms, 3 signs. Remember that's the Alvarado score. That, there are a lot of people who've questioned that scoring, and there are other people who, other scoring system. But the one that is most common, I'm sorry, there shouldn't be an A. It's Alvarado, not Alvarado. It's Alvarado. So there's no second A. It's Alvarado score. Symptoms of pain starting around the umbilicus or as a matter of fact, in the epigastrium. It can start in the epigastrium migrating down into the right iliac fossa. Together with that, there's anorexia, nausea, vomiting. So the three symptoms, the three signs are a temperature of more than 37.3 degrees Celsius and a tenderness in the right iliac fossa and about 10 minutes. The lab test which completes the Alvarado score is a total leukocyte count of more than 10,000 and a neutrophil count of more than 65,000. That allows you the scoring system. If the higher the score, it allows you to predict the presence of appendicitis. Right. Now identify the system that's shown. What are the separate parts as labeled? What is the use of each in the surgical procedure that is carried out? Now, this is a classic PPH gun. So what are the parts that are shown? There's a PPH. Number one is the entire stapling part. Number two is the suturing piece. So that is the thing that you use for suturing. Number three is an anal retractor. Number four is an anal speculum. Number five is a barb suture retractor. So essentially, parts are this that you have, um, that's a protective cover in front from the start so that you don't damage any part of the mucosa. You have the nail retrainer out here and a suture withdrawal hole and on top you have this. This is the indicator for tissue thickness, and that's a safety switch, and that is the adjuster knob. So as I said, you open you first put in uh, the put in the that one that part with the you put in the anal retractor with the anal speculum in. So once you've got that in, then you assess the piles. You fix these. If you notice that there are gaps out here, you fix these to the skin. So once you fix that to the skin, you now put in this suturing piece and you go beyond that. You see marks 1, 2, 3, 4. You go beyond that and stitch it because otherwise, if you go down below, you're inevitably going to go towards the dentate line, and the patient is going to keep on complaining and complaining about your surgery. It's going to be very painful. Therefore, so if we go to the next one now, right? So for a start, let me choose that color. So that is what it looks like inside. Now I've fixed in the speculum, which is white, and you can see that that is the speculum fixed on the side, and it's got gaps out there. These gaps have to be fitted to, skin stitches taken with the surrounding skin. And initially, I used to use silk. Um, the perineal skin is quite sensitive, so I migrated to a monofilament for this. So that fixes it. And now, if you can see what we are trying to do is we fix that bit. I think what we should do is might have a video somewhere. So what we are going to do is we're going to put that in. You notice that. And we fix that bit to the skin. So we go back there. You go back there. Now, what happens is you put in this piece, the the suturing piece. Once you put the suturing piece in out there, I'm going to draw that out in white again. So once that suturing piece is there, and the markings are there. So you have markings 1, 2, 3, 4. So you actually go beyond that area and you take a bite of the mucosa. It's important to take a bite only of the mucosa and not of the muscle down below. So you rotate that. It goes on. You can rotate that bit. So that part rotates and you follow it up. So when you finish, you actually end up having a purse string. You have a purse string in the mucosa like, hang on, like so. You've got a purse string of the entire mucosa out here, which contains all the piles masses. So you've got the piles masses collected out here. So now you open up, it cannot be detached, not like the circular stapler. You open this up and you put in the anvil, and you have two sutures. The two sutures have to be the sutures out there, which I've shown out here. You throw in the first knot, and then this goes in. There are two orifices out here. So that is one. The other one goes in out here through the thing out here. So you put in another knot out here, finish up that knot. Then you tighten it, allowing the two ends to come together, and you pick up the mucosa completely inside, the mucosa only, and that pull is maintained on the side to make sure that the piles are all inside that. So it is caught in it. And now you tighten it till that red mark reaches the green out here. So that goes this way. Tightening is this way. So how do you tighten? You use that adjuster knot to tighten. The safety switch is still kept. Once it has reached out here, that is the time that you remove the safety switch and you fire the gun. Hold it for about 30 seconds after you fire the gun. Then you open it, fix off the safety switch once again, open the adjuster nut, make sure that nothing is held, and then you gradually take it out with the belt. Once you've taken it out, you open out the specimen. You must make sure that you have the entire uh, mucosa only, without no muscle. There shouldn't be any muscle inside. If you've taken the muscle out, there's likely that you've gone in too deep, and that might create a problem. So remember, guys, that is something that you need to remember. I think I might have a video. I'm afraid I don't have the video. Now, what is this instrument? That was the PPH gun. What is this? Here, the anvil can be completely taken out. This is a circular stapler. The circular stapler is for anastomosis. So inevitably, if you're using it for anastomosis, you need two parts of the bowel. You need one bowel coming in from the top out here. You've got a purse string around out here. So there's a purse string around the anvil. So the anvil is detachable, as I said. So let's draw the anvil in a different color. That's the anvil. And that is the stem. And you've got the purse string all around out here. Right. And you need the other part of the bowel, which is out here. No, sorry, I don't need that color. I need pink. So you've got another part of the bowel out here, and that contains the entire anvil. So you've got that's the anvil, and that's the gun. And the gun, if I can show it in this color, so that's the gun without the anvil. The anvil is detached. But when you rotate that round, there's a spike sort of a thing that comes through. So inevitably, before you tighten it, there are two ways you can do it. Either you staple and you go through the staplers. So it's called a double stapling technique. Double stapling technique. So that is what you mean by a double stapling technique. You know, you staple that area and then you push this through that stapled area, and there's a second layer of staplers. So essentially, you have one layer of staplers. So that's your layer of staplers, one layer of staplers, and that goes across like that. And that spike can, if you push that spike through, that can come through out here. So you have another, this is one layer of staplers, and you have the second layer of stapler when this fires. So you have another layer of staplers that goes across out here. So that's the double stapling technique. The other technique is to ensure that that spike is out. And once that spike is out, you put in another purse string around out here, around this end. You you marry these two, it fixes on. So once it fixes on, that slips in out here and it fixes, and then you tighten that and these two come together. Once it comes together, then you have the advantage of, once it comes together, you have the advantage of, hang on. So now you have that out here, and the gun, which is fixed out here. Now, when you tighten it, they both come together. And so you can well imagine that these are the stapling rows, two rows of staplers. Medtronics does one where you have three layers of staplers. So it's for safety. So you actually end up anastomosing from here to there. So that's a circular stapler that's being used. That's the difference between a PPH gun and a circular stapler. I thought I would like to show you both, one after the other. So that's a circular stapler, circular anastomosis, and do it in a low anterior anastomosis. You can do a pouch anal anastomosis, where you've taken the entire colon and rectum out, and you have left the anal canal behind. So you can get a purse string on the anal canal or do a stapler, and then make a ileoanal, might make a jet ileal pouch. Can make my preference is for a J pouch, and you can do the anastomosis out here, a pouch anal anastomosis. The anvil goes into the pouch, and the stem comes out, and you push the other end through. Either ensure that the spike, you put in a purse string and the purse string goes around the spike, and at the end of the procedure, you click both the anvil and the gun together, and you tighten it, and you do a very relatively easy circular anastomosis. The other one is an esophageal enteral anastomosis. It could be an esophageal gastroscopy. You could be doing a jejunostomy or even a esophageal colostomy, if you're using colonic replacement. Either way. So that's what you need to do. If you're actually pulling in the entire colon up to the neck, that is where you will not use a circular stapler, because you have the pharynx of the duct, and that's entirely a hand-sewn anastomosis. So if in the neck, you will not use, if you've put the colon up to the neck, you will not use this gun. Don't use a circular stapler.